So please be seated. Burn Symposium, a session dedicated to one of the most challenging and multidisciplinary areas of patient care. Burn management requires precision, innovation, and compassion, from acute resuscitation to long-term rehabilitation. This symposium will explore advances in the management of burn injuries, including novel approaches to wound coverage, dressing techniques, and cellular therapies. The session will be chaired by Dr. Amila Shashindaratnayake, consultant plastic surgeon at National Hospital of Sri Lanka, and Dr. Nalika Karunaratna, consultant intensivist at National Hospital of Sri Lanka. And this session will also be moderated by Dr. Jeevan Rankothkumbura, consultant plastic surgeon. We are privileged to have a distinguished panel of experts who will share their insights and experience in this vital field. Over to you, sirs.
Good afternoon and welcome to the Burn Symposium in Trauma Conference 2025. And I think next hour will be, the audience will be nourished by novel information and knowledge on modern day burns management. And I expect this session to be out of traditional way, like a more interactive session. So we have three distinguished speakers today, and I would like to invite Dr. Amila Shashindaratnayake, consultant plastic surgeon from National Hospital Sri Lanka, to introduce our speakers.
Yeah, thank you, Jeevan. We have three speakers. First, I would like to invite Professor Sharmila Dissanaike, who is chair of the surgery at University of New Mexico, formerly Peter C. Carnicero Chair, and University Distinguished Professor at Texas Tech, clinically acute trauma, burns and acute. She's a burns and acute care surgeon and a researcher. And she's also a national academic surgeon, leader with multiple leadership roles in American College of Surgeons and American Burn Association, Southwest Surgical and other regional societies. And also she is a board of director of publicly listed biotechnology. She is going to, I'll invite her to the stage. And also I would like to invite Dr. Gayan Ekanayake, who is the consultant plastic surgeon in National Hospital of Sri Lanka. He is also looking after the burns unit of National Hospital of Sri Lanka. And also he is a member of editorial board of Sri Lanka Journal of Surgery, assistant editor, the College of Surgeons of Sri Lanka, and also secretary of College of Surgeons of Sri Lanka in 2020, and Sri Lankan Association of Cleft Lip, Palate and Craniofacial Anomalies, and also multiple roles in plastic surgery. And also we have another distinguished speaker, Professor Sameera Samarakoon, is going to be a very useful resource person to our burn care in Sri Lanka. He is a professor in cell and molecular biology, IBMBB, University of Colombo, and also he's an associate editor, International Biochemistry and Physiology. Okay, so we'll start with Professor Sharmila. She's going to deliver a speech on burns in a polytrauma patient. Over to you.
All right, thank you. So one of the things I want to talk about is why should people who are not burn surgeons know about burns, right? And to me, a lot of it actually goes to the fact that we'll see burns even if you're not a burn specialist, because there are quite a few patients who have both combined burn and trauma injuries. Burns have more metabolic derangements in large burns than any other injury, and there's always a shortage of people who are specialized in burn. So I think it's important for us all to know a little bit about it. I did my training as well as most of my career in Lubbock, Texas, as you heard earlier, and what those things are, if you don't know, are oil drills. So this is oil country in West Texas, and so there's a lot of oil fields. And those tend to give you a high number of injuries that are both burns and trauma. And so we would often have a patient who comes in looking like this. It could be from multiple mechanisms, but someone who perhaps had an explosion, got thrown, has some injuries, has some burns. And one of the big questions is it's sometimes difficult to know where to start. And people tend to get very focused on the burn. And so I wanted to talk a little bit about some of the basics about looking after burns, and 5 main things: how to calculate burn size, when to resuscitate and how, when you need to worry about smoke inhalation, fasciotomy and escharotomy indications, and then just a little bit about wound care. The reason I mentioned wound care last is that I do find sometimes when my colleagues who are not burn surgeons are faced with a burn, they tend to focus a lot on, oh, we need to do wound care. You know, that's kind of something they focus on when it's probably the least important thing in the early phase. So firstly, how to calculate burn size. So I'm sure a lot of you have heard about the rule of nines. It's very simple. It's not very intuitive. Our brains process tens, the decimal system, a lot easier than nines, so that's a problem. But other than that, you know, where it's 9 for each arm, 18 for the leg, 18 for the torso, front and back each, it's fairly easy to use the rule of nines. One thing to remember is first-degree burns do not count. So first degree is like a bad sunburn. It's blanching a little bit. It's pink or red, but it's not a full-thickness burn. You should not be counting first-degree burns. What I prefer to train people to do, especially if you're not used to this, is to use the rule of 1%, the Palmer rule instead. And what the rule of 1 is that the size of your hand, including the fingers, is 1% of your total body surface area. It's important to remember this is the patient, their hand, their body surface area, not yours. I can tell you I've seen a lot of times people using their own hand. It's like, no, that doesn't work. So what I do is I take a piece of paper, trace the patient's hand, cut it out, and then I use that over the burn. And that'll probably give you the most accurate estimate of how big that burn is. It's quite easy to do, quick, even in a big burn. So I would recommend you consider using that. When people use the rule of nines, they often very badly overestimate the burns. So the next thing I wanted to talk about is, when do you intubate for smoke inhalation? So 3 things. I like to keep it simple, 1, 2, 3. If you have 2 out of the 3, you should consider intubating prophylactically. So what are the 3 things? 1 is mechanism. So do they have a mechanism for inhalation injury? You don't just need a fire. You need a fire in a closed space. If you have a bonfire outside, you're not going to get a smoke inhalation injury almost ever, because it dissipates before it gets hot enough to burn the airway. If you have a fire inside a garage, I promise you can definitely get a bad inhalation injury. So closed space. I see patients who are intubated sometimes and they had a fire outside. There's no real risk of inhalation injury, but people kind of panicked. They burnt their eyebrows and someone intubated them. So first think about mechanism, and it has to be a closed space. Do they have hoarseness, dyspnea, stridor? Any of those are really a significant concern and should be a strong indication to push towards prophylactic intubation. And then do they have carbonaceous sputum? If you look at some books, they'll tell you things like singed nasal hairs, facial hairs. Please don't take those too seriously. You can get a lot of burns that flash into the face and burn the face a little with absolutely no risk of inhalation. You don't want to intubate all those patients. But if you're not sure, you're probably safer doing a safe, controlled intubation, because very often in these patients, they get a lot of fluid resuscitation, the airway swells, and it becomes harder later on. And so if you're not sure, if you seriously think they might have an inhalation injury, you're probably safer to intubate. Please don't intubate just for pain control. I see this a lot, especially in children. People kind of freak out, In the United States, because our EMTs intubate as well, we tend to be a little more aggressive with intubation in the field. I see a lot of people intubated just for pain control. Not a thing, shouldn't be a thing. So don't think it's as much of a problem here, but it's definitely a problem where I practice. Resuscitation, I'm sure a lot of you have heard about things like the Parkland formula, but remember that all those formulas are just a starting point. The most important thing is to titrate your fluids to your urine output. The goal is 0.5 ml per kilogram per hour for adults, 1 ml per kilogram per hour for children. If you can just remember that, that will really help your patients when you're doing that first 24 hours. A lot of people who are not familiar with burns give too much fluid, they over-resuscitate. I rarely see someone under-resuscitated. Usually the problem these days is people give too much fluid. If they have an electric injury or a very deep burn, you might want to push even in adults to 1 milligram per kilogram per hour, but really you shouldn't be aiming for anything more than that in anyone else. Obviously, remember, if they have a joint trauma and they have bleeding, the bleeding takes priority. Give blood, resuscitate the trauma before you worry too much about the burn. We used to say 4 mils per kilogram per TBSA was the starting estimate. It's now 2 mils. That's the newest ABLS guidelines. For children, we go for 3 mils, and for electrical burns, 4 mils. And this is the starting 24-hour fluid requirements before you start measuring urine output. You give half that volume in the first 8 hours, the second half over the next 16. And again, just to remember, urine output is your goal. Nowadays, we are starting to change. So what I've told you so far is classic burn teaching. But nowadays, we are really shifting towards colloid, albumin. Just wanted to go into that here in just a second. If the patient has myoglobinuria, and I don't know if it shows very well with the light, but that's that classic wine-colored urine, you should be targeting high urine outputs. You can use mannitol. You can alkalinize the urine with some sodium bicarbonate IV. We're not sure if any of that really helps. It's been described. But you definitely want high urine outputs if you see this. In the United States, there was this product called Dissanaike marketed. I don't think we had a big problem with people dying of cyanide poisoning, but everyone was getting this stuff anyway because the company marketed straight to EMTs and paramedics, kind of bypassed us. And so everyone was coming in with purple urine. The picture on the right there is what it looks like when you've had Dissanaike, which is basically hydroxycobalamin, and it turns purple. And so we ended up with this rash of patients that looked like they had myoglobinuria, and it made no sense. And that's when a lot of us burn surgeons started to recognize that this is this Dissanaike causing the problem. So for us, we unfortunately have to use other clinical judgment to decide if it's Dissanaike or myoglobinuria, because it's actually very hard to tell with this stuff. Cyanide poisoning, I really don't think is that big a deal. I think this was just a clever marketing strategy. But if you do worry about it, you can give hydroxycobalamin. You don't need to wait for the brand product. You can just give generic. It works just as well. Remember that you do not want to give diuretics for burn patients in the acute phase. And that you shouldn't really be using this for blood pressure. Blood pressure is a whole separate thing, not really related to the fluid resuscitation in burns. The rule with burns is the Goldilocks rule. It needs to be just right. Not too much, not too little. If you give too much, you end up with this open abdomen. And even to this day, I still see it in some centers when I'm doing verifications. They give too much fluid, and now they're having to do a bedside laparotomy for compartment syndrome. If that's happening, it means you're over-resuscitating, basically. In this day and age, we rarely see that because most centers have become much better about it. And so the trend I was telling you about earlier is that we're starting to use fluid, less fluid, more plasma. This comes from Steve Kahn, who's at the Medical University of South Carolina. They did a nice little study where they kind of did 3 groups. They looked at standard resuscitation, then they looked at resuscitation with plasma rescue, and then people with earlier plasma. And they basically showed that there seems to be some indication of increased survival if you use plasma a little bit earlier, and plasma more so than albumin. Both have been looked at. I know this is a bit hard to read. It comes from Jeff Carter's group in Louisiana. He's actually the current president following me at the ABA. And they kind of think it's because plasma is moderating the endothelial dysfunction that burn patients have, and that's why it has benefit beyond albumin, is the current kind of best guess that we have. And this came from UT Houston, where they also showed that the outcomes seem to be improved in patients who are resuscitated with FFP. So there's a trial going on right now. It's a multi-center trial sponsored out of the University of Colorado, looking at fresh frozen plasma versus albumin. And so just so you know, the use of early colloid is now something that most burn centers in the US are doing in the acute resuscitation period, so something to bear in mind. If you have a burns trauma patient, even better, because we know that plasma is good for trauma patients too. So I would strongly encourage you, if you have a bad, severely injured burn and trauma patient, to consider using FFP in your resuscitation early on. So the fourth point I wanted to talk about is when to perform fasciotomy and escharotomy. One of the things that really makes me unhappy as a burn/trauma surgeon is when I get a transfer into a burn center from a trauma center that is a deep burn and on the extremities, and clearly there's compartment syndrome. They've done an escharotomy, but they didn't do a fasciotomy. I take them to the OR, and it's too late, the muscle's dead, and now I'm doing amputations. There was a young man from the Army base in South Texas, I remember, who got into a car crash, was pinned, badly burnt, came from the El Paso Level 1 Trauma Center, but when I got to him, we went straight to the OR, did fasciotomies, and we actually couldn't save it. He lost 3 out of 4 limbs. And so it's a really devastating thing to have happen, and it's mostly preventable. This is just some pictures of a recent patient I had who's a power line worker. He unfortunately was falling from the little bucket that he was in, and he made the critical mistake of grabbing the electric line with both hands. So of course he had severe burns to his hands, which frankly were worse than the fall, which is only 10 foot. He'd have been better off if he just fell. And so then he ended up sustaining trauma, but also a 10% burn. And I'm sorry I didn't take pictures before we did the surgery, but you can kind of still see that he's contracted in that very classic claw pose. That's what you see with the electric injury. It looks like a claw. And you can see how very swollen that hand is. And this is after the decompressive fasciotomy. The thing to know as a trauma surgeon is, or ER physician or intensivist, if you're cutting into a 3rd-degree burn, it's essentially free, because that's going to have to get excised anyway. So if in doubt, just slice it open, because you might save that person's limb by doing the escharotomy and subsequently the fasciotomy. Fasciotomies are typically done by surgeons. Escharotomies should be able to be done, in my opinion, by everyone. You know, we kind of teach that as part of basic training. So any physician should be able to do an escharotomy, in my opinion, and that's something that's, I think, important for our burn specialists to train our colleagues to do, because it's really easy to do and makes a difference. And so finally, I want to talk a little bit about basic wound care and pain control, because it is the things that people tend to automatically think about. The main priority is to keep the patient warm. Here in Sri Lanka, we probably don't have quite that much of a problem as in some other parts of the country where hypothermia becomes a huge issue. You can defer doing any wound care for 24 hours with pretty much no consequence. So the truth is, everything else that you need to do that first. Don't worry so much about the wound care. Please do not do, the one thing to not do is to take saline or any sort of liquid, soak Curlex or gauze in it, and then wrap that on the patient. It's surprising how many times I see that. I don't know where it's coming from. It doesn't help. If you take a wet gauze and wrap it on the patient, then whenever that gauze has to come down, it's going to be very, very painful for the patient. The wet just makes them cold. It doesn't help at all. So please, whatever you do, do not wrap your patient in wet gauze. It's much better to just throw a blanket on them and do nothing else. That's a much better way to manage this burn. So no wet gauze, no matter what. And again, if you remember nothing else from the talk but that, that'll be a good thing. If you have the time, the patient's stable, and you want to do some wound care, then the best thing to do is to get some warm water, wash off the burn. If the tissue just falls off, then let it fall off. Don't scrape it, don't go to any great effort, but you let it wash off. And then you want some sort of lubricating ointment. In the US, I tend to use Aquaphor, which is a water-based ointment. You can use aloe vera-based ointments. It can be anything. Whatever is cheap and water-based ointment, that's the thing to use. We don't like to use oil-based ointments, Vaseline, petroleum that much. It's okay if that's all you have, but if you have a water-based ointment, that's better. And then if you have Silvadene or one of those standard burn ointments, that's okay as well. I don't love Silvadene because it kind of forms a slough and that's just kind of annoying. You got to scrape it off when they get to the burn center. But if you have that and you want to use it, that's fine. The most important thing to know about burns and burn wounds is that the best thing you can possibly do is do surgery and remove the burn as early as possible. This does vary across the world. A lot of countries, they do delayed excision, but the science, I believe, supports very strongly that the best results are if you have early excision and grafting, and early is usually defined as within 5 days. What you put on the burn is of much less importance than a full thickness burn being excised in a timely fashion. So in summary, I think it's really important that everyone taking care of trauma patients has some idea about how to take care of the burn patient. They won't be that common, but that's why it's important to know what to do, because it's not something you're just going to get muscle memory remembering how to care for. Resuscitation is probably the most important thing in the first 24 hours. And to resuscitate, you kind of have to know burn size and know how to calculate that. You need to know when to intubate, and you need to know when to do escharotomy and when to do fasciotomy. So hopefully with that, I hope we have time for questions later on, but always happy to, anyone's welcome to contact me or find me here at the conference to talk a little bit more. You know, growing burn care among non-burn surgeons is one of my passions because there's never going to be enough burn surgeons to take care of all the patients. So I very much appreciate all of you paying attention to this population as part of your otherwise non-burn involved work. Thank you.
Thank you very much, Professor Sharmila, for that. Yeah, you can sit here. So, since we have more time, if you have any burning questions, we can take the questions from Professor Sharmila. So, I'll ask a question then. How do we manage the pain in the burn patients?
That's a great question. So the question was how to manage pain in burn patients. Healthcare professionals, physicians, we tend to overestimate the pain, honestly. To me, I would say you manage it like you manage in any other patient, right? So the patient complains of pain. I would start with whatever your standard opioid is, right? So morphine, fentanyl, Dilaudid, whatever your standard version of the opioid is, and give the standard dose you would give for trauma for anyone else. You know, I would start, for example, with 100 mics of fentanyl for the average size adult, and then just titrate based on that. Very often when people are treating pain in burn patients, we're actually treating ourselves, we're not treating the patient. And so it's much more important to just try to mentally separate from what the burn looks like and just see how the patient is doing. A lot of times the burns, if a significant component are third degree, the pain is going to be less than you would imagine. And that's why it's just important to treat them like any other patient and just like you would manage pain in anyone else. Down the road, after you've got them initially stabilized, you would definitely want to add multimodal analgesia, nonsteroidals, things like that, and so that you can not have to do very high opioids. But if they do have a large burn in the United States, the burn center that I've been at for over 20 years, we would actually use low-dose methadone, was one of our favorite opioids that we could give orally that gave really good long-term pain control. We use NSAIDs to help sort of as multimodal regimen. We include it. In general, in trauma and burns as well, we develop multimodal regimens. So we'll use like a nerve agent. The ones used in the US are gabapentin or Lyrica. It's basically for neuropathic pain. Then we'll use some NSAIDs, and then we'll use Toradol or ibuprofen or something, and then an opioid as well, with the goal of reducing the opioids. You don't have this problem as much in Sri Lanka, but in the United States we have a huge problem with opioids and addiction, and so we've really tried over the last decade to reduce opioids, and that's why almost everyone gets put immediately onto a multimodal regimen.
Any other questions? Thank you very much, ma'am. So we'll move on to the next speaker. Will be Dr. Gayan Ekanayake, As an prompt to his speech, I'm showing this picture, a patient I got early this week. She's a 22-year-old female patient who was lighting some camphor on hand and carrying it around the house as a ritual in the house in the evening. And to add to the story, unfortunately, this lady tripped over at the doorstep where her husband was repairing a machine, keeping some petrol with him. So everything get ignited and everything flashed on her burn, causing a almost full thickness burn on her face and the neck region. And as you see, the first three pictures are at the time of presentation or early hours, and after initial burn scrub, and at day 5, she's intubated on the table, ready for another surgery. I think what to do in this situation? These questions will be answered in this next lecture.
It's a great honor to be here among the greats like Professor Sharmila, Dissanaike, and a lot of our known faces. But we are just going to go through some of the things that we are experiencing now, as well as our sort of, we can't call it our innovation, but things that we do here, and seems to be working for us. And so yeah, that's one of my sculpts, but you can go on the next one. You can, sorry. I'm not going to talk about the whole scale of burns problem in Sri Lanka, because it's still it changes from season to season, and it depends on which part of the country you are in and type of things that you can throw at people. So that means the acid changes from region to region. I think Jeevan gets more rubber industry things thrown at people. Here it's a jewelry industry causing very devastating injuries. So now our goals are, I'm sorry about the size, but I'm just going to focus on our experience with some of the superficial burns treatment that we have, especially in our skin type, where we don't want to see lighter scars or darker scars, because our skin is brown, and we tend to do, I would say, unpredictable when it comes to burns in our skin complexion and those things. So, and we have these are some of the measures that we have taken through. As you can see, this is a slide that shows how sort of a skin is regenerating, epidermis is regenerating, and it's growing. They are like water bubbles that are just floating towards each other, and it's just trying to cover the surface. It happens in a funny way. I'll just go through some of the you might not appreciate that it's just one nidus that sends out all these keratinocytes one after the other and on top of the other. So we thought it was initially going single layer going and touching each other and proliferating one on top of each other, but it doesn't happen like that. It's sort of the layers are more towards a nidus, and then it just goes on to coalesce and forming things like this. And then finally the melanocytes do release the melanin into the keratinocytes. They engulf them, and they disperse this color. So this, as you can see, our skin behaves a little bit differently, because we are producing more and more erratic levels of melanin post burn. So this study came from Pakistan. Actually, they used 0.1% beta methylation. It's a very small dose, and they showed that the return of color, or the color balancing, is much better in superficial burns. And it is we are certainly using it, and we are seeing some good results with it. So, but there are some pitfalls. You can't use it more than a week, and that's all. You're supposed to use it, and you have to diagnose a superficial burn, so you don't get the discoloration of skin after a burn, superficial burn. These are the limitations that I don't want to everybody to start using betamethasone next day, but these things are available, so you can actually save the skin color of certain, certainly in our skin type. So the next question is, when it happens to the neck, like what Jeevan showed us, the neck is like a web because of the burn and also because of the platysma. As you know, the platysma is in the almost in the skin, so it's getting attached to the dermis, and we have done the studies on histology of this platysma, what happens to the platysma, and platysma get infiltrated with inflammatory cells, and it undergoes what we know now is a very odd fibrosis. Especially, you get a web neck in people with neck burns. Especially mid-dermal and deep dermal burns, we do see this phenomena, and it's very difficult to treat, and the patients are very unhappy. So we tend to, we had a case series way back in 2008 done by Dr. Chandini Pereira, and this was done for post-burn neck contractures. So we've done the same, and we didn't want these patients to get a contracture. So what we did was to remove the source of contracture. So one is the burn, other one is the platysma. And the platysmectomy is done, and then the neck is grafted with sheets, very large sheets, and they actually do really well. And this neck, unlike the other normal neck, doesn't age. So it just doesn't have wrinkles, never wrinkles. So it just stay beautiful. They really like their outcome, considering the other areas that get burnt. So this is one thing that we have done, and just immediate platysmectomy, and after deep neck burns, we have a good series. We'll probably publish it very soon, and this is just off the shelf. And next is fat grafting in burns, because this is coming up as a new avenue to get, especially the pliability of the skin following a burn, as well as the quality of the skin following a burn. When you see, and even donor sites, we see the donor sites also undergo some sort of scar, dermal scarring, because the dermis will always recover with, it will never regenerate. It will recover with some sort of scarring. So epidermis will always recover completely, regenerate, but the dermis will always undergo some sort of scarring. So there are newer modalities like artificial dermis, and using some of the dermal matrices, that we can actually give the matrix to the dermis to be regenerated. But what is going to happen to those who didn't get it? So this is one area that we see now. A lot of patients also, the color also improves, especially the hyperpigmentation also improves in these patients. Of course, the type of fat is probably the microfat to nanofat. So that means the size of the fat globules has to be regulated, and someone needs to do it in a properly trained person should be doing it. And the other important area is negative pressure wound therapy in burns. We tend to see a lot of full thickness burns coming through, and they tend to, we actually temporize the wound with negative pressure wound therapy. It's not the end, so it is not a treatment option. It's a temporizing measure towards the completion of the treatment protocol. So there are a few best practices. So you need to know that you cannot use on a infected wound. You cannot put on a area which is colonized, because it's not going to help in the decrease the colonization if it is grossly colonized with Pseudomonas. Especially the sponge is going to get colonized very soon, and you might need to remove it in a day or two. Other thing is, if you, as a source of infection underneath, if you just put a negative pressure wound therapy, and you just the the area which is not getting, getting the treatment will anyway undergo infection, and they will have infection and probably suppuration under the vac machine also. And tissue expansion is again coming back. We've been getting some of the tissue expanders to work for us. The problem is with the tissue expanders is that it's a cumbersome thing. You can actually resurface the entire face sometimes with tissue expanders on the neck and expanding the skin and covering the entire face. But it has its own demerits because the explantation rate or the removal rate is very high. It's close to 40% in our series. And also the patients need to come every week or twice a week to get the saline injected into the port. Especially in kids, it's a bit cumbersome because they hate it. Okay, the skin bank is something that is new, and just want to give you an idea. So we have cryopreservation in Sri Lanka. Unfortunately, the manpower is extremely low. As you know, the burns unit is closed now because there are no doctors in the unit except myself and one doctor who is just, even if you get a burn this week, be sure that we are not there to help you out. So that's the situation. Hopefully it will be sorted out by the ministry very soon. So running a skin bank is a daunting task. We need to be there, and we are actually teamed up with currently with the organ retrieval team. So they actually take the consent for skin. This is something we don't really judge. We only have to screen the skin. We don't need to do HLA matching or ABO matching. So we just have it, and it's usually treated with antibiotics and also stored in liquid nitrogen, so we can take it and use it as a biological dressing when we don't have enough skin. So those are some of the things that we've been trying to develop in the country, and I think that's where it stands now. So as summary, I would say that in Sri Lankan context, we love to innovate. We know that there are so many local innovations that can withstand this much of burns that we are receiving, and the country's money is actually spent. The public funds are spent sometimes without any benefit to the patient, because simply because there are a lot of obstacles to get through. Thank you so much.
Any questions from the audience?
So in acute burns at the moment, what is the survivable percentage of deep skin burn, and also what are the immediate skin cover that you all use in the current practice in Colombo?
So our mortality rate we were guarding the mortality rate going. It was going up because of things that we have started, especially the MU score, that early warning scoring system, where when we see a patient going down, we detect them fairly early, and we had our intensivists coming and critical care specialists, especially getting a critical care specialist to do a round and pick up early signs and manage that situation was quite helpful. So it actually went up to especially in male population, it went up to 60%. So what we call is almost like LD 50. We can 50% of survival in what we can get 50% survival in a percentage burn. That is sort of a denominator. Is it the same thing still, Sharmila?
So I think the LD50 is what a lot of us use, but in the US what we've done, because the mortality for burns has dropped so much in the last few decades with both two things I would say in the US mainly. It's great critical care. We've got so far advanced now in critical care modalities and early excision and grafting that we actually can't, there is no LD50 for just the percentage burn anymore because most burns should survive. Even 90% above should survive these days in the United States and most developed countries. So what we do is the revised box score, BAUX, and what that is the person's age, plus their TBSA, their total body surface area burnt, plus if they have inhalation injury, you add 17. And for the most part now, the fatal, in most advanced burn centers, the fatal box score is somewhere like 112, 113. That's where you're going to go, this isn't survivable. But for the most part, you can have a very large burn now in a developed burn center, and you should still survive in both adults and children. So we are going from burns being a specialty where we kind of thought everyone used to die to being a specialty where now with some of the modern technology and the skin substitutes that we have, that we kind of expect almost everyone to live. And yeah, I'd love to know what it is in Sri Lanka. I'll tell you, I work with some people in Zambia, and in Zambia, the LD50 is still around 35% TBSA. So huge differences in survival across the world in burns, way more discrepancy actually than there is in trauma.
Yeah, I think in males it's around 60 in Sri Lanka, and females it's hovering around 45 to 50. So it depends on the age and the other comorbidities when it comes. But in kids, we do save them up to 90% in Sri Lanka as well. So that's a great show by the Lady Ridgeway team. I've seen only one pediatric burn death my entire career, 25 career. So that means, that says that they shouldn't die basically. So we can actually emulate that in what Sharmila said. For dressings or immediate skin cover, we would love to have more skin in the skin bank, because excision. If you excise a burn wound, you can't leave it open. That's proven. So we don't have to, again say if you shouldn't cut a burn and leave it open like a wound. And if you are removing something, you have to seal it, so the infection rates are less. And burns are the only incidents that we say that antibiotic containing or the antibacterial containing dressings should go. That showed the survival benefit. It was about 30, 40 years ago, so it must be valid still. So the silver dressings are there, and but it's specifically for burns. I appeal to you, don't use it for chronic burns, because chronic wounds, because they are very expensive, and people have been using, abusing it like nothing. And when a burn patient comes, you don't have silver dressings in your hospital. So so we are not doing enough. That's what I know, and we would love to have more skin in the skin bank, because that's a very easier to get that. But superficial burns, the collagen dressings, now we have good collagen dressings that we can lay it, and you don't need to do anything, just send the patient home with the superficial burns. So they just fall off. It's like BioBrain, which is a bioengineered one, which is what is available in developed nation. But what we have is processed collagen sheets, which are equally good for our purpose. But that other thing can be used as a temporary measure to excise the burn and just cover it with the collagen, the dual layer collagen with silicone layer. We tried to do that with collagen and spraying silicone on it, but it didn't work, and it just didn't work. So that's the situation at the moment. But you can use, certainly you can use the silver dressing, or even silver sulfur diazine on, but if you are using it, you need to put it on a dressing and put it on the patient. If you just apply on the patient, it's going to cause a eschar on the patient, so it's not going to help in the long run. It's very difficult to take it off. Thank you.
Thank you very much, Dr. Gayan Ekanayake.
Thank you, sir. So, the last but not the least speaker will be Professor Samarakoon. Can I have the slide, please? So, I'm going to show another patient whom I got 2 weeks ago. This is a 66-year-old female with diabetes and hypertension. Came up with a flame burn happened while she was trying to light up some trash, and got fire in her clothes, and almost full thickness burn, almost 66%, 47%. So we talked about the BOS score. So BOS score come to 130. She didn't have any inhalation injury. So now I am in a very difficult situation, especially in a resource poor setting, to manage this patient. But I think in the modern world, this is a salvageable, as already Prof. Sharmila said. This is something salvageable. So Prof. Sameera's talk will, I think, enlighten you on what are the modern strategies, how they will help to salvage these sort of patients. Over to you, sir.
Good evening. It is an honor to be here today at this valuable event. Thank you for inviting me. Actually, today I have made this small presentation based on a particular incident. I think 1 year ago I met Dr. Gayan at our institution, and we came up with a new idea. Today I will try to present mainly that outcome of that meeting, from lab to life, transforming burn care through cell-based therapies in Sri Lanka. I'm not going to discuss more about the general introduction, since both speakers have already discussed them. Anyway, it is a global concern. Burns are categorized as a global concern. More than 180,000 annual deaths are reported. If we consider burns in Sri Lankan context, I think already other speakers there have mentioned. Anyway, I think Dr. Gayan will agree with me. It has reported like it has categorized under high burn incident country. And also, as he mentioned, there is a gap as well as gap in the infrastructure as well as treatment for burn care. Anyway, at the NHSL, they have established a well organized management setup for burns under these experts. Anyway, there are some limitations in the conventional burn care. These are the limitations I'm not going to discuss in detail. If we focus the main aim of this talk, cell culture in advanced burn therapy. How can we align cell culture techniques and cell-based manipulations in the burn therapy? Cell culture is an in vitro technique for growing and maintaining cells under controlled specific environment. Just we can use cell cultures and those techniques for the study purpose. At the same time, we can use them for the development of therapeutic applications. Now, here in this, under this combined effort, we are focusing on development of a therapeutic application. Now, what will be the involvement of cell culture and cell culture techniques in the management of burn incidents? It enables regeneration beyond wound, close. Patient-derived cells restore epidermal structure and function, shift treatment from repair to the regeneration. This term is very, very important. Here we are trying to emphasize or enhance the regenerative power of the skin. Now, if you look at clinical rationale of cultured cell-based therapies, when you take a small biopsy, when you take small piece of skin, just you can multiply it up to millions and billions of cells under in vitro condition. That is the advantage we have. Then finally, we can use these cells for coverage of large complex wound. Mainly, as you know, there are some segments in the skin like dermis and epidermis. There are some different types of cells in the skin. Why keratinocyte, specifically keratinocyte matters? It is a primary epidermal cell type and also rapid wound re-epithelialization activity can be seen. Now, the concept of autologous keratinocyte-based therapy, actually, this is very, this is not new technique. This is common in developed countries, but in the Sri Lankan scenario, still we are not using that type of technology for the burn management. When we think about the structure of the skin here, epidermis, then the basal cell layer, and then you can see the dermis. There are some specific enzymes like trypsin and dispase. By using these different types of enzymes, we can separate those layers as well as cells in an in vitro setup. Provides permanent coverage for deep and polytrauma burns. Can be applied this cell-based technology. Now, application of autologous keratinocyte cultures. Now, as I mentioned, if you have a burn, then you can take a small piece of skin from the same patient and isolate keratinocytes and other cells separately in an in vitro setup. At IBMBB University of Colombo, we are maintaining more than 40 types of different cancer and normal cell lines. We are not going to talk about those type of cell culture techniques. Here, we are focusing on primary cultures that we are going to establish with the support of the small skin pieces. Then you can multiply cells in an in vitro setup. Now, in this combined effort, we plan to do 3 activities. At the beginning, we are trying to optimize a cell spray to manage burns. And in the second step, we are trying to make a thin cell layer to apply on the selected areas of the burn. Then finally, it's a long-term target. we are trying to develop a skin layer with the support of 3D bioprinting. In that case, now already we have isolated some metrogels from seaweeds in our lab. Now we are thinking how can we incorporate those technology with the 3D bioprinting and cell-based therapies. What are the benefits of using keratinocyte cultures? We can provide permanent skin coverage, reduce immunorejections, since we are going to get the biopsy from the same patient. Then there are many other benefits, including reduce donor site morbidity, and so on. Now, this type of machines can be seen to inject cultured cells into the burn. Now, as I mentioned previously, there are many commercially available kits or methods to manipulate skin regeneration. These are some examples. There are some methods and kits available in the world. Most of them are approved by FDA. But the main challenge here in the Sri Lankan scenario, it is very, very expensive. It is like about 6,000 to 7,000 US dollars. Right? Now, in the proposed project, we are looking for some output which can be utilized for our patient at low cost. This is also another example. Here, this has been derived from a mouse stem cells. The challenge here is, if you apply this technology during a burn, you cannot give your blood or any other tissue in the future. There will be some immunorejections as well. Then 3D bioprinting is another well-established technology in the world for many, many health-related applications. 3D bioprinting with cell-based bioinks, the future of burn care. This is available, but here, now we are discussing what will be our plans. Sometimes we will be able to make our own 3D bioprinter here. Now we are at a discussion with a particular party. Or if we have money or sponsors, now we are planning to buy a 3D bioprinter in near future to make a skin layer. Development of cutting-edge cell-based therapies for skin wound and burn care in Sri Lanka. This is new to Sri Lanka actually. That's why we plan our work in 3 steps. In the first step, we are planning to make the cell spray and thick, thin skin layer, finally 3D printed cell layer. These are our objectives. I'm not going to discuss in more detail. Anyway, we have up to now the progress. We tried one optimization with the biopsy. We were able to isolate cells now, but due to some lack of some ingredients at the lab, we were not able to multiply it as we expected. Now, within next few months, we are planning to optimize the cell spray. this is the procedure that we are going to conduct. Actually, this will end up with a good results definitely, based on our experience and the contribution given by the NHSL. This will be a collaborative work between National Burn Center, National Hospital Sri Lanka, and Institute of Biochemistry, Molecular Biology and Biotechnology, University of Colombo. Thank you very much.
It's actually a comment, so because donor sites, as you know, that we think the skin grafts are the easiest things to harvest, and it's most patient-friendly thing. It's actually not, because skin graft donor site is one of the most horrible things that we can give to a patient. So the donor site takes about 2 years to, especially in our skin type, to settle. They have to wear pressure garments, it's itchy, they can't sleep, and it sometimes ulcerates, sometimes become hypertrophic scars, they're ugly, and especially in kids, they hate them. And so I think this is actually, it's still same technology that has been there for 2 centuries now. I mean, we have not progressed beyond, so we should be developing printing rather than the skin, rather than using the patient's own skin. We think it's an easy way out. I would do a flap any day that you can close primarily over a skin graft, which I know because it's more patient-friendly to have a single line rather than a whole thigh getting mutilated. So I think your contribution will actually, if you can develop this to Sri Lankans, it will be an amazing thing for poor patients, so they can actually lead a better life. Thank you so much.
Thank you.